Sometimes people come into skilled nursing, just any healthcare organization, and they have an attitude. They're upset about a lot of things. I mean, think about it. They're in a nursing home now. This is where they're stuck for the rest of their lives. Sometimes they don't have family that really cares. They're thinking about all the things they used to be able to do, and now they can't do. I've had a resident before who wanted to eat regular food. He had stage 4 cancer. He was dying. He was on hospice. Well, are we allowed to help him eat the food that might kill him? I mean, you can lose your humanity as a healthcare operator. One big thing that my old facility I used to work at and was getting someone off a ventilator. I think one year we were able to get about 8 people off the ventilator, and there were 2 young people who were able to go home. Treat them how you would want your other people to be treated. So if that was your grandmother, or if that was your daughter, or that was you, how would you want to be treated?
Welcome to Cartography, a show about healthcare and having practical conversations with people who understand the healthcare system from different angles, from doctors and nurses to administrators and operators, to coordinators and patient advocates, and other healthcare professionals who see where the system works, where it breaks down, and what can be done better. Today, we're going to talk about a part of healthcare that nearly every family eventually encounters, but very few people truly understand it until they're in the middle of it: skilled nursing, rehabilitation, and long-term care. With us today is Brent Vonsuello, a licensed nursing home administrator and operator of Chestnut Ridge Nursing and Rehabilitation, Cumming, Georgia, just north of Atlanta. Brent is a licensed practical nurse and has a master's in public health from Morehouse School of Medicine. Brent, welcome. We're happy to have you here.
Thank you. Thank you.
So, obviously, you have a very unique perspective on healthcare because of your clinical experience, your facility leadership, regulatory knowledge, and just a broader public health view. So I'd really like to talk to you about your path into healthcare, and also what families misunderstand the most about skilled nursing and long-term care. So let's start with your path. How did you get here?
Yes, so I wanted to go to school for marine biology. My mother was encouraging me to go towards nursing. I have 4 aunts that are nurses, and they've worked in nursing for years. I think by the time, some are now in their 30, 40 years in nursing. So I was encouraged by them to go to nursing, and I did, and I got into the nursing program. I became a licensed practical nurse. From that point, I wanted to see more what was out there. I met someone who was telling me to look into management, and I knew my path was going towards administration as a nursing home administrator, and eventually I moved to Pennsylvania and got my license, and actually just moved back down to Georgia.
So what do you do, Chestnut Ridge? How would you describe your role and your day-to-day?
My role is managing the facility. I have about almost 17 department heads, from nursing to dietary, and a lot of the families might have issues about just different people in different departments. My job is to collaborate with everybody to make sure that we can handle an issue. There's a lot of meetings. There are a lot of times where we involve outside vendors like hospice. And also we have home health that when we send people home on rehab, they do get home health at home as well. So we're working with multiple vendors on trying to make sure that they get everything they need in the facility and outside the facility when they go home.
And you're in charge of orchestrating that entire endeavor.
Yes.
That must be quite the day-to-day.
Yeah, it's a lot. It's a lot because there's a lot that a lot of families look to you to solve their problems. A lot of families want answers now sometimes, and you have to get other people involved to get the answer they need. So it's a lot because if they're looking to you as, hey, you're the administrator, we want you to fix this. And also when the regulators, the CMS, the state, when they come through the facility, they're not looking for anybody else except the administrator. And so anything that happens in the facility, it's on me because I have a license, and that license is on that facility.
And how many patients does Chestnut Ridge currently service?
We currently service about 130, but we can have up to 150 patients in the facility.
And so you're on the administration side now. Do you think that you having experience on the nursing side has had an impact on how you lead the facility?
Definitely. I think that when I can easily talk to the nurses and CNAs, and I can actually show them how to handle certain things, and also give them I tell them to come to me. So if there's issues where they're like, well, I'm not sure it should be done this way, yeah, they can go to the director of nursing, they can go to the assistant director of nursing, other nurses in management, but I keep it open that they can come to me. And I tell them if they need help pulling patients in the bed, helping cleaning patients, getting patients into the Hoyer lift, I'm willing to help them. So they enjoy that, but I also can educate them just on basic things I've learned in my years as a nurse that they might not know because we get a lot of new people into the field. And also, it just shows, I think they like that ability to come to me and not feel like, oh my gosh, the administrator is not going to want to be involved or bothered. I just like that being a nurse, I can relate to them and understand what they're going through.
Public health, what drew you to the public health aspect?
Sometimes you'll talk to patients and then you'll realize, oh, it's probably because they live in a bad area that they're dealing with certain disease processes like sarcoidosis, high asthma, and you'll notice, oh, it's because they might live next to a factory or near pollution. So I kind of correlate towards that when we talk about healthcare and what we deal with as patients. And I've always been interested in public health issues, but when I had the opportunity with Morehouse, I really took that. I took it because I said, I want to learn more about public health. And I realized a lot of those things correlate to how the patients, when they come to the nursing home, the things they dealt with in their, where they're around, the water they drink, that deals with how they are now in the nursing home. And so I just thought it was important, especially when I'm dealing with patients. Yeah.
Yeah, so looking at your career now to this point, do you see yourself more as a healthcare operator, a patient advocate, a systems person, or a combination?
I would definitely say combination between a healthcare operator and advocating for patients. When you work in, especially skilled nursing, you it's more sometimes cutthroat because you have insurances cutting people. Especially if you're with a for-profit company, you can't just have someone in your facility who's not paying. So you have those issues, but then you also want to make sure that that patient um, they're being discharged home. Are they, do they have a good system that they can go back to? Because sadly, you learn that families aren't together like that anymore. Sometimes people, especially now, you'll see a lot of people in homelessness, poverty, and the elderly. So them being at a nursing home and they can't work and now they can't pay their bills. So are they going to go back to home to lights being cut off? So those are things I think about as well. And the social worker, they think about those things as well. And if I have to deal with with my corporation, the owner of the company to ensure that the resident is safe, then I'm going to do that because I also look at it towards a regulation standard. If I discharge somebody and it was not safe, how would they look at me as an administrator? So I bring that up a lot when we have discussions about discharges. But I also understand that this company is a for-profit company. So you have to kind of work all together and bring that together. Because if you don't, then to me, you can lose your humanity as a healthcare operator. And then you can also not think about how important the business is because they have to make their money. So you got to think about both of those things when you're dealing with healthcare.
Seems like a very delicate dance.
Yes.
Because, obviously, providing the patient care that's necessary, giving them what they need, treating them with dignity, I think as you mentioned, while at the same time ensuring that keep the lights on, the doors open.
Yeah.
It seems both those are very, very relevant things. So you mentioned skilled nursing. What does that mean?
Skilled nursing to me is just, nurses are already skilled, but when you're dealing with skilled nursing, that's normally involved in a nursing home. You can, and you have nurses who are skilled to take care of certain things. So peg tubes, trachs, ventilators. It could be drains, colostomies, urostomies. So that's the skilled part. And nurses have to hone on those skills. And you're just making sure that these nurses have those skills to take care of the people.
So it seems that the skilled nursing part really is a focus on the long-term aspect for a very specific population of patients. Would that be right?
Yes, I mean it's focused on the long term, but it's also focused on those short term patients. So those residents who are coming in and they broke their hip, they broke their knee, they have a knee replacement, and they need to discharge from the facility. Probably the goal is in 2 or 3 weeks. The nurses are using their skills and making sure that they can take care of those people appropriately. And then you have those long term people who sometimes will have equipment needed to take care of them. And so because yeah, you'll get patients who don't need much; they just need one medication. But then you get patients who have 10 medications, and then they need a lot of care, and they might need a lot more skill. They have a peg tube, they have a colostomy, and so that's when those nurses are using those skills. So I mean, to me, all nursing is skilled, but especially in nursing homes, long-term care facilities, that's when I think of skilled nursing.
So I think a lot of us, when we think of nursing homes, we typically think of the elderly, and I'm sure it's a big part of the patient population. But are there other patient types who might fit the mold of a nursing facility?
Yeah, so sadly, people are having strokes at a younger age, heart attacks at a younger age, kidney failure at an earlier age. So we do get people who are in their 50s, sometimes 40s and 60s, who are not even above the Medicare age of 65, and they're coming to our building and they need sometimes long-term care or they need rehab. So you do receive that. I have seen skilled nursing homes also receive younger people. I used to be an administrator of a ventilator facility, and sadly, we received a lot of people who might have had tragic accidents that have happened, especially young people. Might be injuries from car accidents, gunshot victims, and they're on a ventilator and they need care because of their condition. So I have seen younger people in nursing homes. Most of the time, though, it's because of a sad, tragic accident. Sometimes it's because they have a disease process like ALS. And we do have people currently with ALS at our facility. And normally, most of the time, uh, the ALS triggers in their early, late 30s, early 40s. And so they're pretty much still young, and now they're in a nursing home being taken care of. So I have seen different populations, and I think it's based on where you're at. But the majority of our patients probably are 60s to 70s, and they're normally there for either long term or short term.
So when it comes to, let's say, younger people who might find themselves in a skilled nursing facility, especially those who've come out of tragic events, who may have been discharged from hospital, do you see at least some subset of those people who eventually leave and go home?
One big thing that my old facility I used to work at in Pennsylvania was getting someone off a ventilator. And I think one year we were able to get about 8 people off the ventilator. And there were 2 young people who were able to go home. And so I did see those things. And, that was pretty good because, I mean, being able to walk and do your own thing, and then now you're stuck at a nursing home, a skilled nursing home, and you're on a ventilator. That messes with your mind, especially depression. And so I have seen people transition. I've also seen younger people who've had strokes, and it could be because they're younger. They're doing therapy, and now they're not 100%, but they're at 80%. They might need a walker still, but now they can speak. They had speech therapy, they had physical therapy, occupational therapy, and now they're able to go home and take care of themselves. So I have seen that in my facilities, but also other facilities I've helped out with.
So you've mentioned rehabilitation, long-term care. What is the difference between those two, or is there a common relationship between them?
I would say there's a common relationship and also there's a difference. So to me, long term normally means those people who will be there for the rest of their lives. I think that's the main reason why CMS set up their guidelines and their regulations, because they want to make sure those people who are long term are being taken care of properly. And so there's a lot that's involved, and that goes from them having the right to their rights as patients, but also to them having a resident counsel, residents to advocate for themselves. But then you also have your skilled part, and normally those people are there for a little bit, and the goal is to get them home or with family. But sometimes the long term, they might need some rehab because they're kind of declining, and so yeah, then you'll get your skilled day. You'll get their skilled training in the OT, the PT, the speech therapist will come there, and they will see how they can evaluate and can we make them better.
Just so everyone is aware, OT, PT, what are those positions and what do they do?
Oh yeah, occupational therapists. Their main job is to make sure that you can do the things that you would normally do on your own. You can kind of say just like wipe your butt when that's something that we always do. We're used to doing. Eat, put clothes on. So occupational therapists are very important to the skilled nursing platform and long term because as people are in the nursing home for a long time, they start losing some of the functions that they're able to do. And so their job is to get people back to those points that, hey, can you put your clothes back on? I mean, we do have nurses and CNAs to help with that, but it's so much better if someone can do it on their own.
Ideally, if someone's lost that function, they would always obviously want to restore it, right?
Yes.
And it's in everyone's best interest.
Yes, in everyone's best interest. And so that is a big, that's a big push always in skilled nursing. Physical therapists, pretty much, they work with your legs. They work with your arms as well, but the legs are some of the biggest things when they're helping people walk. I mean, that's what people want to do. You want to be able to walk to do the things you can do. And so that's when we get physical therapy in. And then we also get speech therapy because of their ability to eat certain foods and also to communicate properly. Sadly, strokes can change a lot in people. And that's why you need speech therapy.
So you touched briefly on Center for Medicare, Medicaid, federal programs. What do families typically not understand or not know when it comes to Medicaid, Medicare, or other types of federal benefit programs?
I think a lot of people don't realize that Medicaid is a program that if you own property, if you own things and you want to go towards Medicaid to help pay for your stay because you're going to be a long-term person in a healthcare facility, nursing home, they want the finances. And this is when people have to know that, okay, well, mom's going to go into a nursing home, but we don't want her to lose all her money. So we're going to take that money at the account and give it to her children, or we're going to put her house into her son's name. And it's in that 5-year look back. Medicaid is going to look back and say, no, we're not going to approve her Medicaid. So a lot of people don't understand that. And I have seen, sadly, sometimes their loved one goes to a nursing home, they know it's going to be long term, and then we're doing the verification for Medicaid eligibility, and they don't get it because all the things they did on the account. And they're just very strict. They want to know where the money went. They want to know who spent the money, what did you spend it for. So if you're taking unless you can like we had a patient, I just remember years ago, I had a patient who she was kind of just using her money, wanted to blow it, spending on shopping sprees. She didn't realize that she was going to be in a nursing home in another year. And now she's here at our facility long term, and Medicaid they wanted to know why was this money spent. And the family had to prove that she did not know she was going to go into a nursing home in a year from that point. And they did. And so, but that's how strict they are. They were like, hey, you're spending $5,000 here, $2,000 here, $10,000 here. But she was just doing that because that's what she wanted to do. And she can do that. You can do what you want. But Medicaid wanted to make sure you did it the right way. So I always tell people, they don't understand Medicaid because they're like, oh, well, why do they want all this information? Well, that is a government program that is paying for your loved one's care or for your care. And they want to know, especially if you have money and you have that money, you own property, they want to know everything. And if you're refusing to give that over, they're going to deny you Medicaid. And then that kind of creates a problem on my side because now I don't have a payer source for you unless you pay out of pocket. That and pretty much normally when it goes to the Medicaid part, you're pretty much paying out of pocket to Medicaid for your care until you use your funds up to a certain amount. So, and I know it's different per different state. Different states have different how much the residents are allowed to keep, but they're allowed to keep a certain amount. Sometimes it's $70, and that's all that resident gets from that point. Everything else goes to Medicaid. If you had a house and it's $1 million, if you sell that house, all that goes to Medicaid. Most of it does. So they're very now. If you're married, that's a different story because they can't sell if your wife and you're going to a long term and your wife's still at home. Well, we can't sell the house because she's still there. But it's just certain things that they look at. So I tell people to. Not saying you have to do it now because your loved one is, they want to spend money and go on trips and blow money. That's okay. But if you know that person's eventually going to go to a nursing home, think about how you're handling their money. Because if they see funny things being done, they're going to deny it. And that creates problems.
Right. So this is specific to Medicaid, correct?
Mm-hmm.
And that means if someone is looking to use Medicaid for those services, there's a 5-year look back to see where the money went.
Yes.
Effectively, right?
Yes.
So if you have funds, you can't hide it or give it to a family member, knowing that you're going to be in that long-term facility, right?
Yes, that's correct. Yes.
So what about Medicare? Does Medicare pay for any of that?
So Medicare is a little different. You have Part B, you have Medicare A, you have Part C, and then you have Part D. But especially in skilled nursing, the two that we look at are Medicare Part A. So normally Medicare Part A is when you have most people who get Medicare, especially if they're above 65, they get it when they go to the hospital. And let's say they came there because they broke an ankle, and then now they have a 3-day stay at the hospital, and now they have a nursing home to go into. We can use their Medicare days. Those Medicare days, normally 100 days, and then it only goes back to 0 if you have a 60-day stay outside a healthcare facility. So if you have 100 days of Medicare, most people, they come to the facility. They normally have a Medicare Advantage programs that they're using. But if we can convert them to Medicare, then normally that conversion allows the facility to use, the therapy dictates how that Medicare, the time is being spent. And so therapy can work with the resident and try to see as much as they can, how many hours they can devote to get that resident to where they need to be before they can discharge. Now, sadly, though, sometimes people can't use all those days because they're not doing well, and you can't justify using those Medicare days. And so that's where you have the issue then, okay, well, now we can't use their Medicare, and now we have to go to Medicaid. Or you got to pay out of pocket if you're going to be here long term. Medicare is it's pretty much one of the highest payers in healthcare, and most skilled nursing facilities look for Medicare because you have that 100 days with Medicare.
Right, but it's after 100 days, that's it. The Medicare will not cover someone long term if they need to just stay there indefinitely. Would that be right?
No, that's when you go to the Medicaid part, and then not only that, now Part B helps with the other things. So when you're thinking about the peg tubes and the trachs and the ventilators and the colostomies, and sometimes with therapy can do some things on Part B when they're a Medicaid resident. But Part A is just, which is commonly used at most nursing homes. Most nursing homes are looking for those Part A people. The thing is, if you can't, if you're not participating in therapy and you're on Part A, therapy is going to have to cut you. Unless you have a skilled reason why you're on Medicare. So like if you have a trach or a ventilator, then that kind of helps with that part. But you can still only use 100 days. So after those 100 days, back to Medicaid or paying out of pocket.
Or if someone purchased a long-term care private insurance policy, right?
Yes, and I used to see those a lot. I don't see them as much.
Why is that?
I think those insurance policies, especially starting in the 90s and 2000s, they're not doing that anymore. So like a lot of people who don't have it from back then, and like in the 90s and 80s, they don't get those because I think those policies pay pretty much everything, and now these policies are only paying a certain amount of days or a certain amount of or a certain amount they would pay for the resident. So I think. I mean, those things sounded great. And I think they see now like, okay, all these people are in their 80s and 70s, and now they're using these policies, and they probably can't afford it. I mean, these insurance companies.
So the economics just never made sense.
Now, I think now they're looking back because I think they weren't thinking, oh, Miss Johnson's going to live to 89, 94. So now they see these people living longer than normal than it was before, and now you have these people in their hundreds, and they're still at the nursing home and they're having to pay that insurance policy. So I think, or assisted living, I think that's just a strain on these insurance companies now. So I think I've read that they're not doing that anymore. They're not giving them that leeway of boom, whenever, how much, it doesn't matter. They're more stricter now about these policies.
Right, so they're becoming more rare, it seems,
Yeah.
in your experience.
Yes.
So what should families know or ask about when they have a family member enter into a skilled nursing facility?
I think the first thing they need to see the quality measures of a facility. They need to see look at their survey binder to see how their last surveys were, because surveys are. That's how a skilled nursing stays open. You have to have the CMS come out and give a survey to the facility. And during COVID, it kind of went crazy. Some buildings weren't surveyed for 3-4 years. But now they're trying to get back on the schedule. Most states are. And they're trying to make sure that every building is surveyed at least once a year. And then you also have complaint surveys. A lot of times complaints could be anything. People can be upset about any issue. They didn't like the CNA from that night before. They didn't like how they felt that morning. There was a smell because their roommate was changed and they're upset about that. So there's a lot of things that people can be upset about. So I think when families come in, they need to look at the survey binder, look at the quality measures, which normally are online. But also just talk to the administrator, talk to the director of nursing, walk through the facility. We do tours all the time. And, a lot of times people they want to smell the facility. Does it smell like urine? Does it smell like feces throughout the hall? They want to see what the residents are doing.
I would assume that would be a bad sign.
Yeah. A lot of times, I've had families come to me and say, oh, it doesn't smell like this other nursing home. Or I'm shocked that this doesn't, I can tell they've been to other places, and I've been to other places, and sometimes it just smells like urine everywhere. It could be because the building's old and they haven't updated the building, but also it could be because patients aren't being changed as quick. So I think that's what people need to see when they go through a nursing home. See how people are interacting, see how look at when call lights are being answered, if they're just touring the facility. Those are some things I say, but I think also talk to the administrator, talk to the director of nursing, talk to the people who are there every day and see how they respond to you. If they're rude, then probably you're not going to a good facility.
They're probably rude to the patients as well, right?
Yeah, they can be. Yeah, so I think those are things that people need to do whenever they are trying to look at a nursing home or what they should look for. I don't think any nursing home is going to be perfect because as an administrator, I have probably 100-something employees that I'm trying to make sure are doing the right thing. And there's a lot of things that can be done to get people on the right boat, but you're always going to have a bad apple somewhere. I think families, and I know people who said they look at the tags and they're like, these don't even make any sense. I don't know what this means. Like, because, you can get a building can get tagged for not having an updated care plan. But I think if they see, hey, there's abuse, and why did the abuse happen? Or if it's about education, or if it's about something in particular, I think that's what families would pay attention to more. Quality measures are how CMS grades your healthcare facilities. So with quality measures, they're looking at the actual quality measures, like if we had trachs, if we had colostomies, if we have Foley catheters. We're not just putting people on Foley catheters just because we want to put them on Foley catheters. There's a diagnosis and a reason why. And
just so everyone's aware, what does a Foley catheter do?
a Foley catheter helps a patient urinate. So normally, there's multiple reasons why. Sometimes people have wounds, and the hospital will put somebody on a Foley catheter to prevent the urine from going into the wound when they urinate, because they can't control the urine. Yeah. Sometimes it's based on whatever incident they got into. So, like I say, they had a car accident and they broke both legs. I have seen people put a Foley catheter in. Now, but when you go to a nursing home, there's a different. Those quality measures don't match with the hospitals. So the hospitals were doing all this, and now they're looking at, well, what are we doing? When we have IVs, it's just, we have to make sure that we're following CMS guidelines when we have certain things. Not saying that we are abusing anybody, but like if you have a Foley catheter in and there's no justifiable diagnosis, which I believe there's only 2 diagnoses that you can have for a Foley catheter, then now you're just having a Foley in. And so now you kind of lose some quality measures. You can also have quality measures on your staffing. It's hard, but they're looking to have more registered nurses in your nursing home. A lot of times registered nurses don't want to work in nursing homes. They have the hospitals, and these hospitals are paying probably a lot more. But the amount of registered nurses, the amount of staffing, your staffing ratios, those are in your quality measures as well.
Sure. So how do you attract good people and retain them and keep the morale up?
We do like Employee of the Month. 2 employees get the Employee of the Month. I encourage residents to give us ideas of who they want, staff to give ideas of who they want, so we can pick an Employee of the Month. We also do a thank you board where staff and families can thank the other staff members, and whoever gets the most thank yous gets a $50 gift card, and we pick 2 people from that point. So I try to do a lot of things for the staff. I try to do events for the staff. I know as a nurse, I've worked at nursing homes, and you'll work and there'll be different events that come up and there's nothing done. Or you don't get, like the night shift is not given anything. So I've seen that. So what I do is I try, if we have events, I want to make sure night shift gets something. I want to make sure that everybody knows, we post it, we come up with ideas. We use a thing called culture committee. So we come up with different things that we're going to do for the culture of the facility. I do a town hall as well. So I actually have a town hall this week on Thursday. And so there I just ask staff, do they have any questions, any ideas? I also bring up some ideas, some issues I have or other people might have in the facility. And then I also give them the opportunity to speak up. If they have complaints or have issues, I want them to discuss those. So that's how I try to work on retaining staff. I think also another issue is no matter what, is pay. They're always looking at pay. So I work with the company to try to see if we can get the pay that they're looking for, because there's a lot of competition out here. So it just depends on what people are looking for, what the nursing assistants are looking for, what the nurses are looking for. I think some people who just want stability and they're just trying to focus on a goal, that's good for them. But I think the ones who transition and might jump over here or go over here and just are looking for the higher dollar amount. I've had employees who've left and then they'll say, you know what, I went to a place that paid $2 more, but they had a bad culture.
So it seems that doing things that you mention helps you retain and keep the people and keep the morale up.
Yes.
And do you think that translates into a higher quality of care?
Yeah, I think it makes them feel more accountable because, okay, they hired me and I want to make sure that I'm doing the right thing. And also, like, one big thing I do is when I walk in my building, I say hi to everybody, residents, staff, and I encourage all the department heads to do the same, because I told them you shouldn't be at a point where you go into a facility and the staff is like, oh, yeah, that lady who comes in, but I don't know who she is because she doesn't say anything to me. They should say, okay, well, I know that's the business office manager. I might not remember her name, but Yeah, that lady who always smiles. And so I try to encourage my staff because I said families should know who you are. Oh, well, the residents. I mean, granted, they're going to know some people based on what we're working with them, but also the staff. And I said the staff shouldn't feel afraid to come to you just to say, "Hey, I got an issue. Can you help me with it?" So that's what I encourage. Because I said, if I can do it, you can do it.
Yeah. So you mentioned that one of your goals is to ensure that patients are treated with dignity and respect. What does that mean in an operational sense? How do you provide that on a day-to-day basis across so many patients and so many employees?
Yeah. So I feel when I bring it to staff about respect and dignity towards the residents, I always say that it's not how your mom, like, oh, I'll treat the resident how you treat your mom, because some people don't treat their families right. I always say you treat them almost like a golden rule. Um, Treat them how you would want your other people to be treated. So if that was your grandmother, or if that was your daughter, or that was you, how would you want to be treated? If you're asking for something simple and then the person's refusing to do it, that's not giving them that respect. Or it, like. And there's simple things when they're taking care of people, making sure the doors are closed, the curtains are closed, telling the patient what they're doing, um, especially for those who are blind and have bad hearing. Um, Give a smile and show, okay, we're going to shower, or try to come up with ways to communicate properly to them. If you tell patients what you're doing, they feel a lot better, because if you just grab them and get them ready and take them to the shower room and they're like, I don't know what happened. Sometimes that's when you get the complaints, because they feel like they were just thrown into a situation.
Taking the time to get them involved in what's happening with them and to them, the residents and the patients, I mean, that's a big part of it.
Yes, yes.
So why do you think the treatment with dignity and respect, why do you think that's such a big issue when it comes to large healthcare systems?
Sometimes people come into skilled nursing, just any healthcare organization, and they have an attitude. They're upset about a lot of things. I mean, think about it. They're in a nursing home now. This is where they're stuck for the rest of their lives. They sometimes they don't have family that really cares. Sometimes they're thinking about all the things they used to be able to do and now they can't do. So these people are thinking about all these things, and now they got to deal with somebody with an attitude at the nursing home. Or if you're at the hospital, the front desk, you get attitude from them. You get attitude from security. I think that kind of just messes up people's attitudes towards the whole healthcare world, because they're like, I'd rather just be at home by myself, or not be bothered, or just do what I want to do. Because if you're getting attitude or you're getting rudeness from other people, so I don't know why it's because I've dealt with people being rude when especially I've gone to offices and no one's talking to you, no one, and then when you you go to the front and the person just throws you the thing and says fill it out, and there's no smiling, they're not even saying hey, how are you? So sadly, I think that's just because how the world is, I could say. But I wish it. I know for me, I try to get my staff to understand, um, with that dignity and the respect aspect, come up with ways on how you handle situations. Even if that resident has an attitude with you, they're rude, they say things that are inappropriate towards you, you can say, okay, I understand you're not happy. I'll go see if someone else can help. Sometimes it could be just you. They don't want to be bothered with you. But yeah, I don't know why the healthcare world is so I don't know, tainted. Because I hear a lot of times people say the nurses, CNAs aren't nice, and it's not just nursing homes, it's hospitals, it's other things. So I wish it could be the change in healthcare. I don't know. I really don't know.
You mentioned that you were regulation, managing compliance as a strong suit of yours. Do you think that compliance and compassion are at odds with each other?
Sometimes it can be. Um, I mean, I could think of an issue I've had where a resident wants something, but compliance, it doesn't work that way. But what the resident wants is not a major issue, but it's just like it doesn't work with being compliant. And I'm not just saying for CMS regulations, but I'm saying it could be compliant to the rules of the facility, or it could be compliant to just our policy on certain things. I think it really depends. Like I've had a resident before who wanted to eat regular food, and he had stage 4 cancer. He was dying. Um, he was on hospice, but hospice. Yeah, he can eat anything he wants because he's on hospice. They already, we already know what his diagnosis is and his care plan. But the resident only had one hand and wanted us to help him eat, and that kind of goes to an issue with, okay, well, are we allowed to help him eat the food that might kill him? And so I look at it that, yeah, I felt bad for the resident, but we couldn't do that. But now what the condition was is they were able to get a family member to come in and help feed him. Shockingly enough, he still lived for a long time, even though he wasn't supposed to eat regular food. So I don't know if that was the wrong diagnosis, but
Or maybe the regular food helped.
it could have. I think it made him. I know it made him more happy, but that's when, to me, like compassion. Like, this guy has stage 4 cancer. His body's already debilitated. He's not happy, but he wants to eat regular food, and then we can't do it. So that's when they kind of like they collide. I understood, and I had compassion for him. And in reality, I think if he was at home, it would be a whole different story. But he was in a skilled nursing home trying to get food that we could not actually go and feed him the way he wanted. We could feed him the parade food, but not the regular food. And he was like, he refused the parade. He said, I'm not eating it. And so now you're at a worry, okay, well, this man's not eating. But hospice came up with an idea. We all came up with as a team to handle that situation.
So speaking of compliance, what do you think is the connection between documentation and quality of care?
I think documentation proves everything that you're doing for that resident, and it shows what type of care we're giving. If people are and I always tell the nurses and CNAs, even if they have a small bowel movement, document it. Even if it's something like you see something that they're doing that, hey, now the resident wasn't able to move their arms and now they're reaching out to grab you and they're making an effort. So, like, let the nurse know, let the therapist know. It's very important because documentation is pretty much how facilities get paid. But also insurance companies and Medicaid or Medicare. I'm not saying they don't want to pay at all, but if they see something incorrectly on those documentation, they're going to want their money back. And so that kind of affects how the operation runs altogether. So if you're, and I have seen nursing homes and other healthcare facilities where the insurance company is saying, we want our money back. We want to make sure that, well, we audited the charts and we saw that you didn't do this properly, or you said that this resident was getting this and it didn't happen. Someone's auditing, and like I tell the nurses and the CNAs, if a resident is a 2-person assist and you document that they're a 1-person assist every night you're working, if I was an auditor and I'm looking and I would say, well, you said, so we were paying you for a 2-person assist for a day that person did 1-person assist. We want that money back. And granted, that might not happen. It might happen, but I tell people to pay attention to how they document, because that's pretty much how the facility gets paid when they send that information up to the state, but also when they send it to the insurance companies. And the insurance companies want updates and they want to see how someone's doing. And also, if nurses don't document, sometimes the insurance company is looking back and saying, well, the therapy's saying they're fine. The nurses are not saying anything.
Why did you do this, right?
Yeah.
Like, why was this done to or for this person?
Yeah. So then they'll cut patients, and now they're saying, well, the patient doesn't need us anymore because you're saying they're good, and it could be because the nurses didn't document anything properly. So nurses documentation is important to just the operation of the company.
So if you were able to give the audience a takeaway, whether it's about skilled nursing facilities or skilled nursing in general, what would that be?
I think some people don't realize it because they might not have loved ones who are there and they might not think about it, but a lot of people as they get older, they're going into the skilled nursing setting as patients. So I I think it's going to affect everybody eventually. So, and not everybody can afford to keep mom at home and dad at home, especially if they have kids they got to take care of and they're dealing with their own things. So, I just think it's important, and people need to know how important it is, and also come up with ways to make sure that these companies are still around, because I have read that a lot more nursing homes are closing more than they used to, sadly.
And if there are there resources available out there for people to educate themselves on skilled nursing and nursing home facilities?
You know, I actually don't think there is. I think unless you go to those like elder care law attorneys, they probably have some of the best information that they can towards skilled nursing long term. But when you outside of looking for a book, it's not a lot of information out there. Sadly, I think it should be. I mean, thinking about it now, you might have advocates who are there to help families navigate through skilled nursing, but I haven't really found that many. I found more books related towards how to run or manage nursing healthcare facilities, but not like how to navigate through it. That's probably something that somebody should
Well,
pick up on.
maybe if you're looking to create a research center or write a book on that, that might be a great opportunity.
Yeah, yeah.
So I do have a one last question for you, and I think this might hit home given your background in public health. If you could change one thing about the healthcare system in America, what would that be?
Oh, I mean, this is just me, but I think everybody should have access to healthcare. Um, I know it's not free, but I think we already spend billions towards healthcare, towards people. Hospitals spend millions on, especially people who don't have insurance. So I think if you made it a system where everybody had access to it, and sadly they might have a stroke or a heart attack, and then now what's going to happen? They go into a nursing home, and then now. If they're not paying, then somebody's going to pay. CMS, Medicare, Medicaid, and it kind of comes right back to we're paying for it anyway. So how about we have a better system where people are encouraged to go and not feeling like, oh my gosh, I'm afraid to go because I can't afford, or I just can't afford the $300 bill to go to an urgent care or a doctor's office. Hey, it's already paid for, and now we're not worried about all these people at a young age going to nursing homes or assisted living because of their comorbidities.
Right. So it seems that there might be a better allocation of resources to help address problems on the front end than only dealing with those in the back end.
Yes, I definitely think so. Because I feel like we're getting the problems at the back end. Not saying everybody's a problem, it's just that we're getting those patients who, they haven't been to the doctors in years and they're in poverty or they can't afford to go to a doctor. And now the only time they went to a doctor is because they went to the hospital and now they're at a skilled nursing home. And granted, they might have put money into the system, but I mean, truthfully, probably most likely we're going to altogether pay for that person being in the nursing home, depending on how long they live there.
Well, Brent, thank you very much for being with us here today. Really appreciate your insight and your expertise. I really enjoyed having you.
Thank you. I appreciate being here. I enjoyed it. I enjoyed it.
Thank you very much for joining us. I hope you found this to be insightful and interesting. And if you have comments or questions, please leave in the comments section down below. And we'll put our contact information out there as well. If you have any questions, please reach out. Thank you very much.